right. Good. We've got the chat box and the Q&A working as well. That's great. Perfect. All right. Hi, everyone. My name is Dr. Sophie Pollon-MacLeod. I'm going to be getting started with the webinar now as you guys all enter. We've got a lot to cover today, so I really want to get started with everything. And yeah, I'm looking forward to this talk with you all today. All right, so just first up, a little bit about me. My name is Sophie. I'm one of the naturopathic doctors here with NutriChem. What makes me different is I am a Menopause Society Certified Practitioner. So not all naturopathic doctors have this designation. All of the women at NutriChem do, which is great, all of our practitioners. My background is in human kinetics or kinesiology. I've had a passion for movement and exercise since I was a young girl, and I did personal training for a very long time as well. So this really kind of combines into my passion for working with women, working to build strong bodies, working on body composition sort of stuff, working on bone health. I've done other courses for osteoporosis as well. So I'm looking forward to going through all of this with you. Last but not least, NutriChem is a family business. My dad, Kent MacLeod, actually started NutriChem. I work with my sisters, I work with my brother, I work with my mother. We are a true family business to all sense. It's all of us all involved with pretty much everything. Yeah, and we love working together sometimes. All right, so first off is why are we doing this talk? Why did I propose that we should do this talk about hormone therapy in 2025, despite all of the information that we are finding online and everything that's going on? I just want to make sure you guys can all hear me okay, correct? Yes, okay, we're good. I'll make sure my volume is good. Oh, someone raised their hand. Can you guys hear me okay? Let's see. Yes. Okay, we're good. Okay, perfect. Good. So, why are we doing this webinar? Why did I say we should just do a very simplified overview of hormone therapy webinar when it's 2025 and there's a lot of information out there? Well, as someone that specializes in this, I work with women every single day and have these conversations every single day. There are still these overarching themes from conversations that I'm having with women. So, first one is acceptance. So, this is something I literally had a conversation with a woman about this yesterday. Isn't it just a natural process of aging to go through menopause? Why am I trying to change a natural process of, aging? So, am I trying to reverse it? So, there's this kind of thought that by doing hormone therapy, you're kind of going against nature. And my response to that is honestly, if we were going with natural kind of everything and we didn't have modern medicine, the average age of humans, we would live to 50, 60 at most, right? And now we're living for women to 83, 84. So it's not, so we're not living in the past, we're living in the present, which is a combination of modern medicine, right? Downplaying. This is another really common theme I see with so many women. I don't feel that bad. I know some of my friends who have had it way worse. So we seem to always be comparing to others and then downplaying our own symptoms. It's not that bad, right? It's okay. There was this, friend of mine who had crazy hot flashes and mine aren't that bad. So we tend to downplay some of our own symptoms, which means that we're not always seeking treatment because we think it's not that bad. Dismissal. This is another really common thing I hear all the time is I tried to talk to my doctor about it, but I was brushed off. So, I wanted to seek help for hormones, but it didn't really go anywhere. And this is another common theme as well. And last but not least is misinformation or fear. So we're still having a lot of misinformation being spread, and it always comes from a friend of a friend or a neighbor or something that you've heard, right? We always tend to kind of pick and choose where we're hearing this information from. And unfortunately, the information isn't coming from credible sources the majority of the time. So before we get started, I actually want to do a quick poll because I want to hear who you guys are for today. So I'm going to launch the poll. And there's two questions. I want to hear kind of age and then why you are attending this webinar. Okay. We've got some. Okay. Awesome. Okay, so we've got the majority is looking like between age 50 to 60, a good amount in 45 to 55. Nice. 60 to 70. Nice. And it looks like everyone is curious, interested. Oh, and there's a few people that are actually on hormone therapy as well. Awesome. Okay, so we've got majority 50 to 60. And then 60, 70, 40, 45. So quite a variability and some women 70 plus. Love that. Okay. So those are the results. Perfect. Really interesting. Awesome. Okay. So for today, what we're going to be talking about in the agenda. So we've got our ABCs. So we're going to do a quick introduction first, a little bit about the history of hormone therapy and why we got to this point in time today where we're still having these conversations and it's one of the, most controversial medications that we have. Then we have assessment, who's a candidate, benefits versus risks, and care. And then we're going to go into a question and answer at the end. The purpose of this talk, what I really want you guys to walk away from is feeling confident in separating fact from fiction, right? Building confidence in your decision making, understanding of hormones and menopause so you can focus on you, right? Once again, this is a common theme. How to stay in your own lane and not be kind of clouded by all the information out there and really make the best decision for you possible. Identifying a framework for how to get started with hormone therapy as well. What does like a roadmap essentially look like? Because that's another big confusion point is how do I start it and what does treatment even look like? So what I really wanted to review before we get started is essentially how we ended up in this place today where there's so much misinformation out there. So first off, Premarin, which is one of the first FDA approved prescription therapies for hormone therapy, which is an oral estrogen therapy, was actually used in the 40s, right? This is not a new medication. It's been around for a long time. They were using it basically to prevent cardiovascular disease and osteoporosis in women. And some of the studies that actually started coming out, like the SWAN trial, which is the study of women across the nation, which was observational, was done from the 40s to the late 90s. It wasn't until 1988 where they did a larger trial, the HERS trial, that was actually on using hormone therapy as a prevention for chronic conditions and heart disease, right? So this is a really important point. When the research was done on hormone therapy, it wasn't done to treat menopausal symptoms. It was done and used as a prevention for health conditions like heart disease and osteoporosis. So that completely changed. Think about using a medication for something completely different than what we're actually using it for now, in a sense, or how we're using it. This led to the one of the largest studies, which was the Women's Health Initiative that was released in 2002. And this is really where things start to change and started to shift because prior to this study, lots of practitioners were prescribing hormone therapy for women. Basically, in this study, where they went wrong is they took a very large range of women in terms of their age. So the average age was around 63, and they took women between 50 to 79, and the majority of women were over 10 years past their final menstrual period. They also used oral estrogens like the Premarins and things like that, which aren't usually prescribed very much anymore. So, using a subset of women that were later, much past their final menstrual period, we saw greater risks. And then this is when kind of the headlines came out, and pretty much the majority of healthcare providers and doctors said, I'm not going to prescribe that anymore. So, a lot of women were left without any support or treatment. This in the right-hand corner, this QR code is essentially a summary of that podcast by one of the actual PIs that was doing that research, which is a great summary overview. Finally, we get into the late 2000s, and this is when further research is done, more accurate research is done. We're kind of narrowing things down, and this is when the timing hypothesis comes in, right? The window of opportunity of using hormone therapy and how we can kind of better gauge those benefits and risks. So, what is menopausal hormone therapy? You'll notice that I'm not using the term hormone replacement therapy. So it's actually changed to just hormone therapy because hormone replacement therapy implies that we are replacing the hormones kind of back to physiological levels when someone's menstruating. That's not the case. I like to say it's a replenishment, it's a top up, it's just increasing them slightly. And this is what we're doing through the menopause transition when those hormone levels are lost. Hormone therapy is essentially either a combination of estrogen and a progesterone, right? Used systemically in the body. An estrogen alone if it's someone that does not have a uterus, or it can also be progesterone alone as well, right? The estrogen is really what is that kind of powerhouse for a lot of those hot flash symptoms, joint pain, brain fog, cardiovascular health, right? I'm going to be touching on these things. And then the progestin or the progesterone essentially protects the uterine lining. And this is another common thing I see and read all the time in articles, right? This quote here, women can suffer from bothersome symptoms, right? It's like, oh, they're bothersome when actually menopausal symptoms can be quite awful, quite debilitating, and they can last for up to 10 years or more. Some women, they kind of pretty much continually experience menopausal symptoms. Okay, so what are the experts saying? This is a really important thing in terms of like how I'm presenting this information to you. I'm not presenting my own information. I'm presenting from the Menopause Society, from the Canadian Gynecological Association, from the Menopause Foundation of Canada, right? So this is the consensus statement on hormone therapy in menopause. And essentially what it's saying is that we recommend menopausal hormone therapy as the first line treatment for vasomotor, which is hot flashes, for menopausal and perimenopausal patients. This is so important to note. And really, the word that kind of sticks out here that you need to pay attention to is first line. First line in medicine basically means this is the first treatment that should be offered to women when they're experiencing these symptoms. Unfortunately, that's not the case for a lot of women. They're not offered this as first line. Of course, it depends if someone is a candidate for hormone therapy, but in terms of the kind of consensus, just like we have for different diseases, we know that there's a first line drug that's offered. Hormone therapy is that first line option for women. So now we're going to get into the assessment. So our assessment here at NutriChem, a naturopathic doctor's assessment, in my practice, it's way more comprehensive than someone might experience if they go to their family doctor or a gynecologist, right? I have the privilege of spending much more time with women to kind of have good conversations, to look a little bit deeper. And once again, the whole purpose of this is so that women feel super confident in their decisions, right? My job isn't to convince anyone, it's to provide as much information and to make sure that we're both on the same page when starting hormone therapy. So, first things first is part of an assessment to understand whether hormone therapy is going to be beneficial for you or whatnot, or the how it's going to be prescribed, is actually understanding what symptoms you're experiencing, what body systems are impacted. You can see here essentially the body systems impacted are many, widespread, and variable. We have estrogen receptors in the brain, in the heart, on the liver, right, in the bones, in the joint, in the muscle. We have these receptors everywhere. So once the estrogen starts to decline, we start to experience those symptoms. So part of an assessment is doing a literal head to toe understanding of what's going on for women and which body systems are most impacted. For some women, it's very much related to the mood. So the anxiety, the depression, the insomnia is a big piece, right? Other women will come and say that they're more pain and it's more inflammation, right? And more brain fog that they're experiencing. So everyone has a very individual experience. So for the type of symptoms that they're experiencing through this transition. And it's so important for your practitioner to understand what those are. Okay. Another big piece of the assessment. So when I did that poll, right, we have a good chunk of women that are in this talk that are in their 40s and then 45 to 55, right? So you still may be having a menstrual cycle. So we need to understand where you're at in your menopause transition. Most women know perimenopause and then they know menopause, right? But actually there are lots of different kind of breakdowns of phases in perimenopause, menopause, and actually post as well. So, what I like to say to women is one, track your menstrual cycles because this really tells us and gives us a solid assessment of where you're at in this transition. In the early perimenopause transition, so this is usually late 30s, early 40s, right? We start to see some cycle changes. We start to see maybe heavy periods, shorter cycles, right? 21 days, 35 days. PMS is more intense, anxiety is more intense. Women coming into my office and saying, I feel like something is up. And then they're getting, lots of information online that they're aligning with. Late perimenopause, we see this is when women come into my office and they're like, oh, I think I had a period in like February, or it was like a couple months ago, I had a little bit. This is the time period where our hormone levels really start to drop because we're not having a cycle as much, and typical menopausal symptoms are much worse. So, those hot flashes, night sweats, joint pain, brain fog, weight gain, all of this occurs, right? Because we're having over 60 days between our cycles. Once you've gone a full year without your period, right, then we're in menopause. And this comes with a whole host of other changes as well, right? Because now the body has gone for much longer without that estrogen. So understanding where you're at in this transition is really important because we can start to see what symptoms you're experiencing and what are some of the other risk factors we may have down the line. And please, this is a note, mark down when your final menstrual period is, right? I have a lot of women that don't know when it is. Open a note in your phone and write down when that is because that's actually a really important date to know when you finished your final period. Blood work and screening. So once again, this is another huge aspect of assessment that is often not really touched upon too much as well. Hormonal blood work, so getting your hormones tested. A lot of women will come to me and say, I asked my doctor to do my hormones, but they didn't run them because it said it's pointless. So the reason behind that is because your hormones fluctuate so much throughout a menstrual cycle, or if you're over a year past your final menstrual period, we know the hormone levels are relatively low as well. So there's kind of those assumptions there. However, there are certain cases where actually checking your hormones are super beneficial and can provide us a lot of information. So, one is when you check your hormones when you're having a menstrual cycle, you don't just do it random. We do it on specific days when we're looking for certain things like your estrogen and your progesterone levels, and it can be super helpful. Another reason why someone might need to get their hormones checked is if they've had a hysterectomy, if they have an IUD, if they have something like PCOS, right? And they're not getting cycles as frequently and they're later into their 40s and they're not sure if it's because of the PCOS or if they're kind of in the menopause transition. Or late perimenopause, like I said, when we start to miss your period, we can look and see kind of where your hormones are at. And this is another important indication for getting those hormones checked. Another really big piece of the assessment and what we do at NutriChem is we look at everything. You would not believe the amount of women who have come into my office that are like, I'm 100% perimenopausal, I'm having fatigue, I'm having anxiety, I'm having brain fog, and I do their blood work for them and they are iron deficient, right? So they're like, well, I was iron deficient when I was in my 20s. Well, you're iron deficient again now because your cycles are heavier and they're shorter, right? And your life is more hectic and you haven't had chance to, take your iron supplements and things like that. So that's very important to kind of note. Other things like thyroid disease or hypothyroid is super common in women, and we see a lot of the same symptoms, same thing that overlap with menopausal symptoms, right? Fatigue, weight gain, digestive issues, anxiety, right? Mood changes, skin changes, hair changes, all of that is also thyroid. So why wouldn't we make sure that there's nothing else overlapping with those symptoms? Any other nutrient deficiencies, B12, vitamin D deficiency, your liver function, cardiovascular health. A lot of women, we don't understand that also menopause can actually really increase the risk of diabetes and prediabetes. And a lot of women will check their blood work, and I will have to say to them, you're in the pre-diabetic range, and this is why you're having these energy crashes and the weight gain, right? And once again, it's not just the hormones, typically it's a combination. For some women, another big piece of the assessment, if they're having really heavy periods or they're having pelvic pain, would be getting a transvaginal ultrasound to make sure that there's no fibroids or polyps that are kind of growing or anything at that time. Mammograms are also very helpful to assess for breast density during the menopause transition or postmenopause. Part of the assessment that we're looking for, and this is kind of like a really big point to come across that most women don't know and don't understand, kind of like who is actually off the table for hormone therapy. So when I explain it to women, I often just explain very simply it is a traffic light system. Green means go, yellow means slow, and red means no. Okay. So when we look at someone who is a good candidate for hormone therapy, typically good overall health earlier in menopause. They're within a few years of their final menstrual period, right? So that's all great. No other underlying health conditions. I'm like, great candidate. Let's get started. Then we have the red and the yellow. So on the red side, essentially, that is someone who would have a history of blood clots. So a pulmonary embolism, a deep vein thrombosis, stroke, any other serious cardiovascular disease. If they've had a personal history of breast cancer or estrogen positive cancers, if essentially postmenopausally they're having bleeding and they're not sure what it's from, we wouldn't do hormone therapy. And if they have severe or active liver disease as well. So those would be people where we would see the risks really outweighing the benefits at that point. Then we have your yellow. So most women will fall into the yellow category. There's always tends to be something, and most women think because they're in the yellow, they're actually a red, right? So that would be a family history of estrogen cancer. So my mom or my aunt or someone had closer to me had breast cancer. That's not a contraindication for hormone therapy. You can still use it. It may mean that we would look a little bit deeper or we would be a little bit more mindful of things or you'd have more regular screening. Other things like increasing age, once again, it doesn't mean you can't start hormone therapy. I've had a lot of women who have basically come in and been like, I suffered for so long and I'm just done. And they're starting hormone therapy at 63, 64, right? Because they tried and it just wasn't working, right? And they started, and that's okay too. High alcohol intake, smoker, any other cardiovascular disease. Once again, yellow just means maybe slow, looking a little bit deeper, and just making sure you have the right practitioner to support you and kind of like make sure you're making the best decision for yourself. And breast density. Advanced screening. So this is 2025, right? So we have the ability to do advanced screening and advanced testing, especially for those that are at greater cardiovascular risk. So if someone comes in, they have a high, what's called the Framingham risk score, it's looking at your cardiovascular risk factors. We may recommend that they actually get further testing done, further testing for blood pressure, doing a stress test, looking at the carotid artery as well, right? This is a great way of helping to improve confidence for someone who's starting hormone therapy that has some of these other risk factors. And we do have collaborations with the Cardiac Longevity Clinic here in Ottawa to help collaborate and work with women who would like to take hormone therapy, but potentially might be at greater risk. All right, benefit versus risk. So this is a really important piece of the way that someone will get prescribed hormone therapy. And this is what I do every day in my job. We're constantly weighing what the benefits and risks are, right? So typically for most women, I say it's just kind of trying to understand where your benefits and where the risks are. And basically for hormone therapy, the younger someone is when they start, the dose, the duration, the type, all of this will impact what the benefits are, right? So it's really not universal from person to person. It's very dependent on that woman and their health history and what their goals are and their symptoms. So I also say for my patients that come in, there's the benefits that are like symptoms that you'll see improvement in, and then you'll see what the benefits are long-term health-wise, right? And then the same thing for the risks. We see what are some side effects, and then what are some of the risks kind of long-term with longer use. So for the benefits for symptoms, right, we know that hormone therapy is very, very effective at helping to manage hot flashes, night sweats, sleep quality, mood, mental health, overall quality of life. Those are all kind of very solid pieces that we are aware of in terms of the benefits of hormone therapy. Long term, what we know is that we can see improved metabolic health, so reduced risk of type 2 diabetes, cardiovascular health, bone health, right? Significant benefit for bone health, genitourinary symptoms, vaginal dryness, urinary tract infections, all of that kind of bundle into, right? Once again, essentially every receptor we have in our body that has estrogen receptors that is going to be impacted by taking hormone therapy. In terms of the risks and adverse effects, right? So risks we see the kind of the main categories are related to the fact that estrogen itself is procoagulatory. It can thicken the blood, right? So that's why estrogen has a risk for certain things like stroke. Usually all of the risks are quite mitigated once again if used younger, type of estrogen, how it's being prescribed, right? Think about the birth control pill. Women that have had like blood clots or who are smokers are not prescribed estrogen-based birth control pills, right? Because of that risk factor. Breast cancer, coronary artery disease as well, right? Once again, this is for women who are initiating much later, and this is based on that study that I mentioned in the beginning. In terms of adverse effects, the most common adverse effects are kind of like PMS type symptoms. So the breast tenderness, the mood swings, headaches or nausea, some fluid retention with progesterone as well. Or you could also have a bit of bleeding and spotting, which typically goes away after the first 3 to 6 months or when it's being prescribed properly, right? So I did put a star at the bottom. There's no increased risk of stroke when women initiate estrogen within 10 years of their final menstrual period as well. And then oral has a greater risk. So once again, this kind of reiterates the benefits. This is from the Canadian Medical Association Journal. They released an amazing article back in 2023, right, in terms of what these benefits are with hormone therapy. Right, two of the big ones that I love talking about are just quality of life, right? So that just kind of puts everything, it's just an umbrella term for women just feeling better in pretty much every facet of their life. We see an improvement in quality of life. We actually see a reduction in coronary artery disease, uh, definitely a reduction in osteoporosis, mood and depression. I always say for women that the earlier you start, if you have a history of depression or anxiety, the better. That's where the research lies for things like depression, sleep. And then there's actually a reduction in overall mortality, right? Especially if starting earlier. So this is the conversation I have with women who are kind of closer to 45 or younger, and they start showing signs of late perimenopause. They're at huge risks if they're actually not doing hormone therapy. This is from the Canadian Cancer Society. So for breast cancer, so basically it's an additional 3 cases for every 1,000 women who use combined therapy for around 5 years. Other risks of cancers like uterine and ovarian cancer are very low. Once again, the uterine cancer is dependent on the dose, the form, and the duration and how someone is being prescribed the hormone therapy. There's some studies for the reduced risk of colorectal cancer, but that research is still relatively early on. All right, then we have this. I absolutely love this graphic here because it puts everything into perspective when it talks about the risks of breast cancer. So we're very, very focused on hormone therapy as a risk factor when in society we don't tend to talk about anything else, any of the other risk factors. So the big ones are a sedentary lifestyle, right? So no exercise, increased alcohol, right? So additional 5 cases for women who are drinking 2 or more units of alcohol per day, smokers, and another big one is obesity or a greater BMI. This is a huge risk for all cancers in general, but breast cancer being one of them as well, right? So we actually do see a lot of these kind of combined risks when we look at, and this is why when we do the assessment and we weigh the benefits of risks, right? If a woman has a lot of different risk factors, then, if she's been on hormone therapy, but she has a history of smoker, was drinking a lot of alcohol her whole life and didn't exercise, um, the breast cancer or any of those could not be just attributed to the hormone therapy. Weight gain. So this is a really common one. I included this in here because it's another really common question I got is is hormone therapy going to make me gain weight? Is it going to make me lose weight, right? Does menopause make me gain weight? It's so common for women to experience these symptoms. So first off, hormonal shifts during menopause can result in weight gain. Is that fact or fiction? Yes, that is a fact, right? So we see a combination of internal influences and external influences that will result in weight gain for women. So essentially, the internal influences are the actual physiological changes that are happening in your body, like with blood sugar, with muscle mass changes, right? Weight distribution without estrogen, right? Weight will kind of get more towards the visceral organs, right? So around the abdomen, versus when we have higher estrogen, it's more towards the breasts and the hips. So body composition starts to really change, right? Hormone therapy can cause weight gain. That is fiction. So we don't see any significant weight gain in any of the research that we've done. On average, they say that women were actually 2.2 pounds less than women that were not taking hormone therapy, right? Whether it's the hormones itself or the fact that once again, that quality of life, you're sleeping better, you're feeling better, you may be eating better, you may be able to move better because you're in less pain, right? So there's so many different influences that could impact someone's weight changes that occur. Lastly is the abdominal weight gain. Like I said, this is a fact, the altered body composition that changes, right? Women will come all the time and will be saying this to me, right? So hormone therapy can help to kind of support the metabolic changes that are happening, right? In combination with all the other therapeutics that we can use to help support this for women. Okay. Lastly, we are going to get into your care. So this is a really important piece. And once again, this isn't universal. Not all women are, getting the same treatment options, getting the same assessments. It is unfortunate there isn't enough or a higher standard of care for women, right? So first off, hormone therapy is most effective and safe when prescribed and managed through a highly individualized approach. I cannot stress this enough, right? This is for women that come in, they're like, I tried hormone therapy and it didn't work for me, right? Because unfortunately, they weren't prescribed it on enough of an individualized basis, right? It wasn't prescribed the right way, right? Every woman has a unique biochemistry, health history, and symptom profile that can impact the dose, form, duration, and use of hormone therapy, right? So all of this will impact how a woman responds to hormones, how they feel on hormones, what their symptoms are, right? So this will impact what is used and what's prescribed. Everyone should have access to treatment with an educated healthcare provider and have the necessary support and education through the hormonal transition of perimenopause and menopause. This is not happening right now. There are so many women that are falling through the cracks in this. I think that the people that are able to come to NutriChem and afford private healthcare have access to someone like myself who can educate them and have time. But not all women are experiencing this, right? And certainly not all healthcare providers have the updated information or just the experience or education to actually be prescribing it properly or know how to prescribe it, or they're still using kind of old standards. I recently had a student shadowing me from the Ottawa Medical School, right? We have student shadows as part of an integrative course. We talked about hormone therapy, and it seems like uh, there's still a lot of controversy where they're not actually educating newly graduated medical doctors to prescribe hormone therapy. They're still saying, even though it's saying first line, they're still prescribing antidepressants and other things, right? So unfortunately, it really hasn't caught up, and we're still not seeing that higher level of standard of care for healthcare providers. Generations of perimenopausal, menopausal women are taking control of their health, advocating for choice. So, who is going to decide how you want to spend 40% of your life, right? So, this is a really important piece of care is you are the decision maker in your treatment and in your care, right? So, you are kind of the driver for what happens next and how you want your menopause transition to look like. A big question that's really important is when should hormone therapy be initiated, right? Historically, and even sometimes I still hear this, it was, well, I have to wait a year until you know, after that, I can start my hormone therapy after a year since my last menstrual period. That's not how it's initiated. Hormone therapy should be initiated essentially as soon as you start experiencing those symptoms. So this can be initiated in perimenopause. The challenge is where, what we see here in this phase, we do see a huge fluctuation and variation of hormones, right? So perimenopause is there's lots of ups and downs, there's lots of fluctuations in our hormones, so it can be a little bit more challenging to prescribe. But you can do it. You can start it right away. I've got women in, mid 40s, early 40s, late 30s, depending on their symptoms that are using hormone therapy, not just prescribed by myself, but also prescribed by their gynecologist or family doctor. The timing, like I said, it does depend on the severity, what their is, and their health history as well. Once someone is in full menopause, so they haven't had a cycle for a year, right? The hormone levels are pretty much like on the low end, right? And they'll stay pretty steady throughout. So it's a little bit easier to initiate therapy at that point. And you can still initiate therapy, like I said. So these are the really important points. So what does hormone therapy actually look like? So like I said before, we have your estrogen therapy and the progesterone therapy. The estrogen therapy, this is kind of what's the most robust aspect of treatment, right? Once again, we have all those receptors in the body. Typically, the route of administration is now topical. Most women are being prescribed topical estrogen therapy. It is a cream that you apply, it is a gel, it is a patch. There's lots of different forms. Some practitioners, I still have some women come in using oral estrogens. It's not as common. There are greater risks with oral estrogen. Then we have the type. So what is actually in those creams and gels, right? So pretty much the majority is now bioidentical. Estrogel is bioidentical, right? What that means is it's exactly what our body is producing itself. It's an estradiol. And 17 beta estradiol, or E2, is essentially the most potent form of estrogen. It means it kind of exerts the greatest effect in the tissues. And this is what is found in the majority of all the prescriptions. Okay. We also do compounded prescriptions for hormone here. This is because not all women respond very well to estradiol. Like I said, those side effects, the breast tenderness, the headaches, the nausea, estradiol can be kind of a little bit potent for some women, so they need lower doses. And sometimes even the lowest dose that's available in generic is too high for them, right? Or they're kind of in perimenopause where they still have some hormone levels and they just need a little top up of their estrogen. This is when a compounded form can be super beneficial for helping women to support their symptoms without any of the other side effects. So this is something I do as well in my practice as a combination of your E2 and E3. It's known as a biest, so it has the two estrogens. And E3 is just a little bit softer of an estrogen. It doesn't exert as much of an effect, but it still has a lot of the benefits similar to estradiol. The dose, right? Like I said, the dose should really be started at the lowest effective dose, and it can be compounded for precise dosing as well. There's certain cases where I would start at a higher dose depending on the severity of symptoms. I've started higher if I see women are at risk of osteoporosis or cardiovascular disease, or if they're younger in age or younger than 45, we're going to be going much higher with the dose. But typically for menopause, for managing of symptoms, we always start with the lowest dose because we can always slowly start to taper up. Then we have your progesterone. Okay, so this is another confusing point for women. They're like, well, do I have to take both or whatnot? So if you do not have a uterus, if you've had a hysterectomy, then you can use estrogen therapy alone. If you do have a uterus, you need to use a combination of estrogen and your progesterone. If you're not taking estrogen, you can use progesterone alone, and perimenopause especially is a really great point to actually use progesterone to help manage the symptoms like the anxiety and the sleep and the hot flashes, because progesterone is pretty chronically low through perimenopause, and we do see higher or fluctuations in your estrogen. So how does progesterone work? It actually acts on the GABA receptors in the brain, and it exerts a very calming, kind of sedating effect, which is why it's usually dosed at night, and women use it for sleep during menopause and perimenopause. The other thing it does and why it's paired with your estrogen is it downregulates those estrogen receptors in the uterus. So to prevent overgrowth of the lining, right? So we're trying to make sure that we don't have a thickened lining and we're not putting ourselves at risk of endometrial hyperplasia or overgrowth. Like I said, really beneficial for anxiety, sleep, even hot flashes and night sweats for some women. Some women will feel really great on progesterone. It can be prescribed in many different ways. So it can be prescribed continuously, so taken all the time. This is usually for someone who's in menopause that has a uterus. If someone is still having a menstrual cycle, it can be dosed during the second half of your menstrual cycle in the luteal phase, kind of like mimicking your menstrual cycle and mimicking the hormone fluctuations there. And oral forms are most common. And typically that's what's known as a micronized progesterone, or prometrium is the common generic name. Essentially, this is bioidentical. It is exactly what we're seeing in your body. Okay. Some women will be prescribed a synthetic or a progestin, MPA or Micronor. Essentially, these ones are a little bit more potent, and they do tend to have more side effects. So most women now are typically put on a progesterone. They'll do much better. If some women don't tolerate it well or they're still having spotting, some women will actually use a Mirena IUD. The IUD is a progestin, and that can help prevent overgrowth or thickening of the uterine lining as well. Topical, once again, this is kind of a star. This is what we do at NutriChem as well, because we're all about individualized dosing and compounding for precision prescribing. Topical is really helpful for some women who just need a little touch or a low dose. So I'm talking about that early perimenopause, using it cyclically, right? Starting to have some symptoms. Topical, we tend to have less kind of side effects as well, and we can really be specific with the doses. Testosterone therapy. I've added this into the talk because I get a lot of questions about testosterone therapy now. Unfortunately, I can only prescribe estrogen and progesterone. I cannot prescribe testosterone. But most women are not taking or being prescribed testosterone anyways. They're curious about it, but it's not an approved drug or prescription. In the one case where it is hypoactive sexual desire disorder, so really severe loss of desire and libido, which is really common for a lot of women. So it would be nice for them to have some testosterone, but it's very hard to get that prescription. You can have some of the side effects like the hair growth. There's really a very significant lack of research in this area as well. And this is why it's not routinely recommended. If I was able to prescribe it, I would probably love to, compound a little bit with progesterone or stuff like that to help women with some of these symptoms like low libido. When should hormone therapy be discontinued? So this is for my patients out there, and you know who you are if you're on this call because I saw you, that are taking hormone therapy well into their 70s, right? So there really is no perfect time. It always about, really weighing out those benefits versus risks. For some women, the risks tend to kind of climb a little bit. Some women, the benefits will remain, right? Or if they try and stop hormone therapy, essentially they'll have all their symptoms return and then their quality of life declines. And we don't really want that either. So it's really individualized and it's really dependent. I do have a lot of women who are going to be hormone therapy for life. They choose to take hormone therapy for ongoing. They do not want to stop. And like I said, I always support women and their choices. This was a statement released from the Menopause Society back in September. This is something they were presenting at one of their conferences, basically starting to look at actual data for women who are taking it more long term into their 70s and their 80s, right? So, once again, research is still preliminary on this, but I think it's really interesting that we're actually starting to look at, when is the age to stop? A lot of kind of typical prescribers might say at age 60 you have to stop taking, or after 5 years you have to stop taking. That could be if a woman does have greater risks. But like I said, it's always about weighing those out and making sure that the woman who is taking the hormone therapy is able to make that decision for herself. So, overall main objectives when we're prescribing hormone therapy or when you're receiving it should be initiated at the lowest effective dose to minimize those side effects and risks. Topical is definitely the preferred route over an oral estrogen therapy. It's prescribed on an individualized basis, so not a one size fits all. And the response should be monitored on an ongoing basis. This is another huge problem that I see for women. They're prescribed hormone therapy by their gynecologist and they don't get to see them for 6 months or a year or even ever because they don't have any follow-up appointments booked. You should be having follow-up appointments to check in on your response. We should be looking at your side effects. We should be making sure that there's no issues. We should be tweaking your hormone therapy and tweaking the doses as necessary. And this is an ongoing thing. So when I start hormone therapy with a woman, I'm checking in with her within 6 to 8 weeks, right? So it can take time to build up the hormones in the body. I want to make sure she's doing well, and I want to make a tweak or adjustment if necessary before she continues. Ongoing, it's usually every 3 to 6 months. And then once again, you're always weighing out those pros and cons as well, right? Because things change, right? Health things can kind of come up, and then you may decide if you want to continue with it or not, depending on what the situation is. Lastly, hormone therapy is effective for women, but should not be the sole focus of treatment. So, this is really important for people listening who are kind of like, maybe tunnel vision on the hormones right now. We have to look at all the other lifestyle factors. As a naturopath, obviously, I'm going to be asking about their stress and, supportive factors, psychological factors, right? What's going on in your life at this time? There's always kind of a peak of, that's why it's the sandwich, it's the kids, and it's the parents that you're taking care of. So it's a really intense time in a woman's life. So we have to take in all of these things when we decide what the treatment is, right? And diet is a huge piece. Your gut health, your microbiome, right? Your nutrients, like I said, hormone therapy should not be the only thing that is discussed to help you through your menopause transition or postmenopause. So quick summary, right? So our A's, we have your assessment, right? That traffic light system, where do we fall into that? Once again, that's up to you, your practitioner, sorry, to help kind of decide whether you're a good candidate for you, as long as they're educated on the fact that there's a yellow zone where some women can definitely still use it. When was your last menstrual period? What's your current age? What's your health status? What are your risk factors, right? So are you engaging in behaviors that can help reduce those risks, like exercising, or are you drinking lots of alcohol? Do you have, high cholesterol? Do you have dense breasts? Is there a genetic component that we need to look into further? Start monitoring your symptoms, right? Start actually doing an inventory of which body systems are impacted by your menopause transition, and get some blood work done. Absolutely get some blood work done. This is so important. There's really nothing better than investing in your health and investing in actually looking to see what's going on inside your body. Benefits versus risks, right? So really the benefits of hormone therapy really outweigh the risks when hormone therapy is prescribed at the right time, dose, and candidate. This is something that we know, right? At this point, right? We know it's beneficial for a symptom reduction, mood, mental health, osteoporosis, cardiovascular and metabolic health, genitourinary health, and just overall quality of life. C, care. Your care should be patient-centered and driven by you. Once again, this is kind of a really important take-home point is my job isn't to make the decision for you, it's to present you with all the information and help support you in making that decision so you feel really confident in what your next steps are and not uncertain and not uneasy about it. The last thing I want is for a woman to feel pressured or feel like, they don't feel comfortable with something, right? So you really have to make sure that you just are educated enough, you have someone that's going to support you through it and kind of walk you through things, and that it is your choice. Individualized approach. Timing and initiation of therapy is key. This is why I'm doing these talks because I really want to capture all the women who are curious about this, and there's more education on it. But it is hard when I see women, who are coming in later in their menopause transition and they say, why didn't anyone talk to me about this? Why wasn't I offered treatment when I was suffering at age 45 and age 50, right? So the timing and the initiation is key. Having these conversations now is key, right? The goals are really to reduce your symptoms, maintain your protection, minimize side effects, and improve your overall health and quality of life. So, what's next? It's a lot of information that I just provided, and I know it's kind of, you know, really, really focusing on the hormone therapy. So, just take a minute to just taking it all in, right? Do a self check, do an inventory of kind of what I discussed, what your symptoms are, right? Maybe if this is something, like I said, that you're interested in, you can take a minute to just say, like, is this the right thing for me? Or am I ready to kind of like take that next step and work with someone like any of us at NutriChem to help support you in this transition. So myself, my sister Emma, Holly, and Leticia, we all are Menopause Society practitioners. So we've all done the exam, we've all completed the further education, and this is a big part of our practice. So you're welcome to scan the QR code and save the NutriChem clinic contact information. I did open up my schedule next Friday just for people who are listening into this webinar who are interested in working with me for hormone therapy or getting started on their journey. You won't find these appointments booked online, and otherwise, I don't have availability until late fall or on my wait list. So, like I said, you can book with me or you can book with some of the other practitioners that are also awesome at NutriChem as well. We're doing a lot of different events in this space. Hormone therapy, this is not new to NutriChem. We've been doing it for a long time since we brought Suzanne Summers to Ottawa back in 2000 when it was very controversial. We're going to be at the upcoming women's show. We're going to be doing, so this is for all your partners or men in your life. We're doing a testosterone focus with Dr. Yusuf Siddiqui. He's our men's health focused, and that's going to be in January. We're working with Dr. Quadwo. That's Emma with him there for a hormone event in the fall as well. He wrote Prevention Over Prescription. He's one of Ottawa's top leading medical doctors in the ICU that is all about integrative medicine and things like exercise and, integrating in the wellness space, which is awesome that we're collaborating with people in the community. Same thing with the cardiac longevity and with Lifespan MD, right? We're really collaborating with spaces, and this is in order to provide our patients with further testing and further assessments that we can't offer as naturopathic doctors, right? So that's why I said with the cardiac longevity clinic for women that are greater cardiovascular risk, we can now refer into the longevity clinic to have the carotid imaging and have those testing because we really want to make sure we're always ahead of the curve when it comes to hormonal support for women. These are some podcasts, some websites that are really good for kind of like further information. And because you've listened into this full webinar also, you can scan this QR code and receive 10% off our webinar collection of NutriChem products that are especially great for menopause. So we've got your collagen, we've got your magnesium, we've got your fiber, vitamin D in there, obviously important for the bones. So all of that is in that collection there. So if I'll give you guys a minute to scan that, and then I'm going to be getting into the questions. Okay. Okay. Okay, so the question and answer box is now open if you guys want to type your questions in there, or I can go through the chat box also. Okay. Oh, wait, we've got one question here. Okay. Okay, thank you, Aaron. So the first question I'll answer is what is the difference between natural HRT and medical HRT? So this is a common kind of question as well. Really, if it's hormone replacement therapy, it is the same thing. So there's a lot of people will say it's bioidentical, but now the common generic forms that are prescribed are all also bioidentical as well. So um, natural hormone therapy is bioidentical hormone therapy. Medical hormone therapy is also is also bioidentical. Next question. Do you need to take progesterone with Vagifem 10 micrograms? So, Vagifem is a vaginal estrogen suppository that's used to treat the genitourinary syndrome of menopause for vaginal dryness, pain, and urinary issues. No, you do not need to take progesterone with it. Some women will like to have that as both if they are at risk of hyperplasia. If you're using the Vagifem properly, the maintenance is around 2 times a week. You don't need a progesterone to take it at the same time. No, because it's vaginally, not systemic. I'm going to answer the question about vaginal estrogens and someone else. I'll just kind of tag on that. So, vaginal estrogen therapy is creams or suppositories that are kind of inserted vaginally, and really they exert a local effect on those tissues. They don't really increase any of those systemic effects. So, the question is, does vaginal estrogen carry the same risks and will it help systemically? So typically, no, it won't help systemically with other symptoms like hot flashes or joint pain or things like that. Some women will actually feel some benefits. Like once again, this is so individual. Some women that use Vagifem and things like that, they'll come back and they'll be like, I feel, I feel great. I feel like I have estrogen in my body. It does increase your levels. It's very low. So it does depend on the sensitivity of the person. But if you're looking to get hormone therapy, then you would need a systemic dose of it, and it would need to be like a cream. There is, however, a hormone therapy that is a higher dose that is inserted vaginally. It's called the Fem ring, and essentially it's vaginal estrogen therapy, but in a much higher dose to exert systemic effects. Okay, so Linda says, if estrogen is such a risk for breast cancer, why is it that most breast cancers happen to older women who are postmenopausal, and why aren't pregnant women at risk? 80% of HR studies concluded that it did not increase, 10% claimed an increase in risk, and 10% claimed a decrease. Why is the science not followed with respect to risk when there is no consistent link? So basically, the question is if it's age or in pregnancy or things like that when it doesn't increase your risk. Essentially, a lot of the cohorts that are kind of what the studies were looking at in terms of reduced risk, they were looking at the groups of women that were taking estrogen alone. So they didn't have a uterus. So that is a kind of another big kind of controversial point where they said that it was the estrogen and progesterone group that showed the increased risk of the breast cancer versus just the estrogen alone. So we did see there is a slight increase, but yes, we know that age is a risk factor also for breast cancer in general. What is the best way to book with me next Friday? You can scan this code and take the clinic contact information and call in or email if you want to get an appointment with me. I don't have it as my online booking. Once again, it's just for the people that are in this webinar who are very interested in having discussions about hormone therapy. Is Premarin the same as estriol? No. Premarin, if we're talking about Premarin, the vaginal estrogen therapy, it is not. Premarin is a synthetic conjugated estrogen, so it's not bioidentical estrogen. Can we start taking HRT in early 40s? Absolutely. Yes. If you're having symptoms and you're experiencing this and maybe you're kind of in the perimenopausal transition, then yes, you can absolutely take hormone therapy in your early 40s. Like I said, it's not always prescribed and it has to be prescribed properly. If you're still having a menstrual cycle, sometimes for some women, this means dosing in the first half of your cycle and then stopping for the second half and using progesterone for the second half. Why is testosterone not easily prescribed in Canada as part of hormone therapy for low libido, and how does this practice compare to other countries? Yes, hi Lara. It's such a great question because, yeah, we do have a little bit more of a conservative approach to hormone therapy for women in Canada. I find this a lot for my patients that are coming from Europe or Brazil. They tend to be offered hormone therapy quite liberally and are typically also prescribed a testosterone. So like once again, like I said, it's because there's not a lot of evidence in terms research in terms of benefit for menopausal symptoms, as well as it's pretty much reserved for women who have like severely low libido. But that's something that a lot of doctors will also say, there's this factor, there's that factor. It's not just because of your hormones. So they won't be prescribed it. But yeah, definitely other countries, I always find the patients that are coming from outside of Canada typically are already taking hormones or were given that option. Can you take HRT if you are over 10 years into postmenopause? Yeah, so once again, this is that yellow light situation where depending on the person, there may be greater risks. However, yeah, you can absolutely take hormone therapy at that point. Like I said, I have had women coming in who are suffering, 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 and then they go see their doctor and they're like, yeah, sure, here you go. You can start it up now, and they're 10 years post. If someone is at a greater, like quite a high cardiovascular risk profile, then I would probably say no. Once again, we want to start the estrogen early before we start to see changes in the arteries and things like that. That's why it's really beneficial for cardiovascular disease early in the menopause transition. What about DHEA? So DHEA is another common prescription. No, we don't have that available readily over the counter in Canada. It is in the US, and more practitioners down south and other countries like in Mexico are using DHEA. No, I cannot prescribe it as a prescription. Some women, this is like a precursor hormone. You can also take it as a vaginal suppository as well. It's called Intra-Rosa. That works really well for painful intercourse or vaginal dryness. But no, I cannot prescribe it, unfortunately. Yeah, absolutely. Yeah, so this person was basically asking if, they're just basically saying there's a lot of other issues. Is it possible to kind of look into everything first? So yes, we can do blood work prior to starting the hormone therapy as well. And this is why I say that's an important part of the assessment as well, right? So if someone comes in and they're like, I've got all this going on, like let's take a look at your blood work first because it gives us a much better idea of what's going on with your hormones. And yes, you can just you can take as much time as you want to decide based on your blood work, based on the treatment. Some women also will say, let's do 3 months of just kind of doing some, natural therapeutics and things like that. I will say, like, I'm a naturopathic doctor, and, there's lots of great over-the-counter supplements that can really help to support periods and PMS and things like that. But for things like hot flashes, night sweats, and that sort of thing, we do see that they're kind of hit or miss when it comes to actually being effective. And this is where the question of, going the natural route for some people, I actually say sometimes for some women, the risk of not taking hormone therapy is actually greater than the risk of taking it. Yes. Is the Cardiac Longevity Clinic a private organization? Yes, it is a private organization, and that's why you can kind of get into the clinic. We can get like I said, if I have a patient who's high cardiovascular risk but would like to take hormone therapy, we can refer you to the longevity clinic to get further assessments, to meet with the cardiologist, to feel like you have like a little bit more information before starting. Yes, yeah. So Linda said we're conservative in this country, and very overly regulated for stuff like this. So yeah, it can be frustrating. Like I said before, there's quite a variability in what treatments are offered from practitioner to practitioner. Yeah, yeah. So take DHEA. Yep. So some women do very well on DHEA. Like I said, it depends on the person. It's not a commonly prescribed practice, and it's not something that the Menopause Society necessarily recommends as adjunctive to treatment. So yeah, so if anyone's interested in booking, like I said, this is the clinic contact information here. You can email or you can call in, or you can even book a discovery call with one of our admins as well, to kind of get more information about the clinic or who you might be best suited working with. Like I said, this is something I love to do. So I have a busy practice, which is great, but I prefer to work with women who are interested in hormone therapy and who are going through this transition. So it's ideal the people that are in this webinar that are curious. And if you want to learn more, like I said, you can call the clinic or check us out on our website as well. Okay. Any other questions? I think that is all. Great. Well, thank you all so much, everybody. Lots to think about. Yeah, like I said, there's lots to think about. Take a minute, take it all in. I'll go back to this slide on the resources too. The Menopause Foundation of Canada is a great website. The Menopause Society has a great website as well for information. Like I said, they all recommend working with a Menopause Society practitioner, and we have all that information up there too. Hi, Kathy. Thank you. Thank you, Julie. I wish I had this information 20 years ago. Yes, I know. It's very. Oh, thank you, Lara. Oh, hi, Christine. I love all my patients that are in this talk. Awesome. Okay.